Hi, I'm Seth Truger. Welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, please feel free to send us your questions or comments at Twitter at JAMA Network Open or in the comments under the Facebook or YouTube videos. We will do our best to keep up, but unfortunately, our remote filming makes it a little bit tougher than it normally is. We've got an interesting paper today, the Association of State Marijuana Legalization Policies for Medical and Recreational Use with Vaping-Associated Lung Disease. Excuse me, sorry, that's a mouthful. And we've got first and senior authors Cody Wing and Alex Hollingsworth. Welcome.
Hi.
Thank you.
Great. So can you two introduce yourselves and tell us a little bit about why you did the paper?
Sure. So my name's Cody Wing. I'm an associate professor at Indiana University. And Alex, I don't know if you want to.
Yeah, so I'm Alex Hollingsworth. I'm assistant professor and health economist at IU's O'Neill School of Public and Environmental Affairs. I generally study how regulations affect public health. I have interest in environmental health, substance abuse, and access to care. In addition to with Cody, this is joint work with Aaron Carroll, who's a physician and researcher at the IU School of Medicine. He's heavily involved in research and in scientific communication. And also this is joint with Ashley Bradford, who's a PhD candidate at O'Neill. She has a really impressive publication on cannabis policy and all sorts of things that are related to public health. I encourage everybody to go check out her work. So Cody, you want to introduce the paper?
Sure. We mainly got started with this because we have another line of work about recreational marijuana laws and medical marijuana laws, and some of that's with Ashley Bradford as well. And I guess the idea was just, that there's this history of prohibition and the regulation of different kinds of drugs and psychoactive substances in the United States. That one of the downsides of that kind of regulation is that you might sort of generate black market activity. And so we thought, if EVALI, right, could be one example of this kind of thing if people are sort of getting the illness. That was an early theory, and I think it seems to be that, the accepted view of things right now is that people are getting EVALI from using a particular kind of marijuana and product, vaping a particular kind of marijuana product. And there's this possibility that, the use of a contaminated form of a vaping product could be unhealthy, and so that's what we wanted to try and look at, right? Whether there were differences in EVALI case rates in places that had legal marijuana versus prohibited marijuana or regulated marijuana.
So going to welcome Ralph and Nate who have joined us. We're talking about EVALI and marijuana legalization. And this is interesting. I feel like this is almost like the state law version of, I'd rather you guys do it inside the house if you're going to do it. Is the question is is it safer to have it legal, regulated, sold through, approved dispensaries as opposed to whatever happens to be on the street and adulterated?
Yeah, certainly. And that's, one of the things in our paper that we can't evaluate is how safe is e-cigarette use or how safe is marijuana use, and is it safer in a regulated environment or not? But certainly that's a motivating question and something that we're interested here. So one sort of potential mechanism that could be driving the results that we have is that it's consistent with sort of the CDC hypothesis that in unregulated markets, there's this addition, as Cody mentioned, he said tainted, but it's this vitamin C acetate to vaping products that contain THC. And it's possible that in the regulated markets that the testing or, the threat of lawsuit, it's unclear exactly why that additive is not in the regulated market, but in any case it's not, is somehow creating a safer product, at least on that one dimension. Right. So that is an important limitation of what we're doing. It's not saying that marijuana use is safe or e-cigarettes are unsafe or either way, but at least on this particular dimension, they seem to be fewer cases in states that have regulated marijuana markets.
Yeah, I mean that's the big point about this paper is that it's an extremely simple analysis that we did, and you should bear that in mind before we go too far out on a limb interpreting what the results might tell us about the world. All we really did was compare the number of cases per million population of EVALI across states that either have recreational marijuana laws or have medical marijuana laws or have prohibited marijuana laws, don't have legalized marijuana laws of any kind. And what we found is the case rates are a lot lower in states that have recreational marijuana laws, and they're much higher in states that have medical laws or that prohibit marijuana completely. That's pretty much the entire paper. I mean, we do a little bit of work to try and adjust for confounding due to e-cigarette use, and don't find that drives the result. But that's the size of it, So there's a lot of other things that could explain these differences, and we aren't able to pin down the mechanism in any deep way. But there's a pretty big difference in the case rates between these different groups of states. That's the point.
And just to, as a note in terms of the methodology, so these were states that had already had legalized marijuana availability, correct? Because I know in recent history, or in the past few years, there have been states that have moved towards that or have changed their policies, which I would imagine would have affected the result, could have affected the results.
Yeah, sure. And that's a difference in policy is super important. So that's work that Ashley has done to go and actually pin down the opening of these recreational dispensaries. So there's a difference, right, between when a recreational law is passed. So, for example, in Colorado in 2012, when voters said, okay, we now have recreational marijuana, they actually made home cultivation and possession legal for 2 years before you could go to a store and purchase marijuana. In DC, there's recreational marijuana on the books, but you can't go to a store to purchase marijuana. So the way that we're using or we're defining recreational marijuana access is there a store that you can go purchase it at? But you're right, you could expect, like if we had, luckily EVALI is not a persistent thing that's been around for a long period of time, but let's say it was, and you could look at within state variation for EVALI, those are the types of changes in policy that would be really important to disentangle. And Cody and I with Ashley have other work that shows that marijuana use is sensitive to those differences in policy that you bring up. So we see that adult use increases quite a bit when a recreational marijuana law is passed, but the main driver of that is when dispensaries open up, which makes some sense. Right?
Yeah.
It's tricky sort of methodologically how to make progress on something like EVALI, I think. So as Alex just mentioned, like in our other line of work, we try to follow states or people over time and see what happens. You can look at a state before and after that state adopts a recreational marijuana law or opens dispensaries, and you can think about building a comparison group of states across that same period of time that didn't change their laws. And that's a stronger design, and you can try to rule out various kinds of threats to validity. Still, that's hardly like an RCT, but it's better than just cross-sectional comparison. Here, EVALI is like we hope, kind of a one-time event, right? It's a new health condition that happened. If you tried to do a time series of it, there'd be like no cases anywhere, and then there'd be a few, and now they're gone forever. So that kind of design where we would look before and after at EVALI case rates, before and after a change in the law, that's just not a feasible way to go about it because there's no pre-period. So we're kind of, for the moment, stuck with what happens in states that have these two different environments. So yeah, it's tricky.
Yeah. And that's actually one of the things I think that's always interesting, both the combination of public health or policy research, as well as just kind of neat little research letters, where the goal here I don't think is to totally answer all the questions, but I think this is I think kind of an archetype for a research letter where we've got some straightforward data. Some comparisons we can make. We can't draw, firm conclusions. But honestly, like the numbers here are, there's some really, I was actually, when I first read the paper, shocked about the difference in the rates that and we have it's shown on the visual abstract, the cases per million in the 7 states with the recreational marijuana use are 1.7, and in the medical marijuana states, the 26 states with medical marijuana, it's 8.8 EVALI cases per million, and 8.1 in the states with complete prohibition. That's a pretty big difference. Again, we can't say which way causality is going. There's so many different things. The rates of EVALI, the number of cases of EVALI are fortunately incredibly low, and it's really hard to say. But I also really enjoyed the invited commentary that accompanied this piece, and went in, some of the parallels with prohibition of alcohol from a century ago, as well as some of the discussion of just some, potential explanations. I think that the explanation for the vitamin E acetate is basically are in the states that don't have legal recreational marijuana are people who are selling it able to get, basically the marijuana vapes from legal states and then using it to kind of, cut the supply, spread it out and sell it more, something like that. Whereas in the other states, there may not be that same kind of financial incentive.
I totally agree. I'm first of all delighted that someone wrote a commentary. It's like one more person reading the paper than usual. So fantastic. But I also think, they did a really nice job of, first of all, setting the historical stage and then kind of conveying to people that it's really not clear how you should properly think about regulating or legalizing drugs. There really are just trade-offs to be had in both cases. Our initial point in the paper, and maybe the easiest interpretation of the results, is that when you ban a substance in some place, you risk creating a black market that could be more dangerous, right? So maybe that's true, or maybe that's what happened here. Who knows? That's sort of what it looks like. But if you legalize something or introduce a new product like e-cigarettes or legal marijuana, right? You probably encourage more people to use marijuana or use e-cigarettes than would have otherwise. And that's also a potentially bad outcome, right? We might not want more teenagers to be vaping. We might not want more teenagers to use marijuana. And the first order guess of what legalization does is leads more people to use marijuana. That's very plausible that happens. So you trying to weigh the pros and cons of like increased risk of EVALI if you don't legalize versus increased use of marijuana if you do legalize. I don't know. You need some framework for thinking about how you value those different trade-offs. It's interesting stuff, and I think that the commentary in a really short space does sort of help you think about those ideas and how they fit into a historical context, which is really interesting.
Yeah, going to welcome a couple other people who are following along. It's Cease Noswell, Jorge Barajas, Aya, and Kelly have joined us, and we are just wrapping up our discussion here on EVALI and state marijuana legalization. So any final thoughts?
No, we're very thankful for the opportunity to discuss our work with you. And again, as Cody said, sort of just more work on this topic is of interest, not necessarily with EVALI, but how different markets for psychoactive substances interact with one another. It's not obvious that a ban on e-cigarettes, for instance, would necessarily reduce EVALI cases, but still a ban might produce other public health benefits, right? So just thinking about the interconnections here, I think is super important. And thank you much for having us on.
Me too. I'm delighted to have been here. I will say one last thing to think about is that all the data are available from this project on the GitHub website. And this is a really easy project. The public use data is available. You could do it with students and compare means and run little tiny regressions if you want to. So have at it if you have a use for them. Thank you.
Well, thanks. We will share that link as well. Thanks for joining us, and take care. Keep up the good work. We've got a few more people who've joined us. We've got Kat and Ryan Guan Chu who've joined us, and we are going to move into our next paper. Angel, what do we have?
So this is effective default options and advanced directives on hospital-free days and care choices among seriously ill patients, a randomized clinical trial by Halpern and colleagues. The objective of this study was to try to look at if offering a default option in the advanced directive influences care choices and also clinical outcomes. So this was an RCT with a little over 500 patients in Pennsylvania, and patients were randomized to 3 groups, either a comfort-promoting plan of care, a life-extending plan of care, or sort of no pre-selected choice. And the trial was essentially kind of, powered to rule out a reduction in hospital-free days in the intervention groups. And so they discuss sort of the results in the per protocol and the modified intention to treat group. In the per protocol group, patients that completed the comfort advanced directives were more likely to choose comfort care. So it's about 63% than those that received standard or life extending advanced directives. In the modified intention to treat group, about almost 34% who completed comfort care advanced directives, 28% who completed standard advanced directives, and 22% who completed life-extending advanced directives chose comfort care, actually. And this is demonstrated in figure 2 nicely. And then the median hospital-free days among patients that were assigned to comfort advanced directives and life-extending advanced directives were non-inferior to those among patients assigned to the standard sort of group. And so all of this is essentially to say that offering default choices in advanced directives in this trial did alter the choices that patients made regarding future care without changing clinical outcomes. So interesting, a little complex there, but I think kind of a cool study thinking about this topic.
Yeah, I really enjoyed that they I think did a great job of trying to have it both ways, basically, and I mean that in a very positive way, where they went for a very good, important clinical outcome of hospital-free days, which is, what we're really going for is to, if people, people aren't going to benefit from being in a hospital doing, pure attempts at curative therapy are probably not best for anybody. But really, they also with that kind of secondary or I don't know, intermediate outcome of what do that people actually do. And figure 2, I think, just shows it so well, where that with these little nudges, we've talked about behavioral economic stuff here a bunch. If you start basically the same form, but it's basically pre-selected as start with comfort care, people are much more likely to choose that. Or if people are, same thing with the flip side, the people who choose who got the default for the life extending attempt were much more likely to choose that. And I think it's just so interesting. It's always interesting to me to see how much, our brains and our choices are pushed by those little nudges.
Yeah, definitely. It's really interesting. And it's also just kind of nice to think about just offering choice. I think we don't always do that. And, there's lots of reasons for that, time constraints and whatnot, but it is kind of nice to see, like, okay, when you offer these options, people actually do, potentially carry them through.
Right. And the thing that's always nice to me, I mean, I'm not a bioethicist, but as a bioethicist had explained it to me at one point, and I think it was in med school, is how, if these choices are ethically equivalent, then do it the way that we can use this as a way to help people make choices that we think might be better. Like if we know in our default, in our system right now, it's probably a lot harder to choose the comfort care overall. Our system's just not set up for that. And if this is one simple little nudge that's the same, I think the big example I've heard before too is with organ donation, where most places it's opt-in for organ donation. But it would be really easy if we all just made it opt-out, but it's ethically equivalent as long as it's not a big hurdle to opt out. It makes a lot of sense, and then we end up, being able to help more people potentially.
Yeah, and this is not coming from like a paternalistic framework
sure.
at all.
Right.
No, but I really like the way that you put that.
Right. Thanks. Yeah. Good welcome. Brody has joined us as well. We're going to move on to a COVID paper. What's this one on?
So this is a research letter, possible transmission of severe acute respiratory syndrome coronavirus 2 in a public VAC center I'm going to try my best to pronounce this. I apologize if I don't pronounce it correctly. Huai'an, Jiangsu province, China, by Will and colleagues. So this is a very interesting letter that's reporting on a cluster spreading event in this area of Huai'an, which is about 700 kilometers northeast of Wuhan. And so they found that a Bath Center for Men in January of 2020 had this event where, I'm just going to go through the sequence here, but essentially patient 1 had traveled to Wuhan and then went to the Bath Center first. He had fevers the next day, and then a few days later was diagnosed with COVID-19. And then the next 7 patients that ended up also contracting COVID-19 used the sauna and other and swam in the Bath Center and used other facilities there on subsequent days, with the last patient actually being the last patient diagnosed being the person who actually worked at the Bath Center. And they also kind of go through some of the clinical characteristics. Most of the patients had fever and cough. all 9 patients had ground glass opacities rather on CT. All of the patients ended up not requiring respiratory support. And they make a point, which I thought was sort of interesting, that this is sort of a unique situation because apparently other respiratory viruses have demonstrated temperature and humidity sensitivities. And I suppose like the VAC center is both humid and has high temperatures. And so I think their point was, this virus was able to have sort of sustained transmission over several days, I should say.
Yeah, I thought that this was really interesting too, and especially just with there's so much we don't know about COVID-19 that these sort of things can be really helpful, and just even just looking at the figure where it's just literally just a calendar and when people were in the bath center, when they had symptoms, what they were, and how long it took for the test to be positive is just fascinating. One thing was I found it interesting that there's only 9 patients here, so it's hard to draw any real definitive conclusions. It's a pretty small sample, but none of the patients had diarrhea, and I didn't see anything in here reported about other abdominal symptoms. And I think in both my experience talking to colleagues and some of the other data I've seen, probably about a quarter to a third of patients have some pretty pronounced abdominal symptoms, even pretty frank pain. So I was a little, it's again, only 9 patients, hard to know. And it's also one of those things where until you start looking for it, it's hard to find those things.
Right.
So again, I'm also probably, I'm sure that I'm biased or frame my thoughts about it based on the first couple of patients I saw who may have been surprising, et cetera. So
yeah, no, definitely. Very, very interesting.
But yeah, interesting. I also found it kind of interesting in this one that it was the employee who got it last in this case series.
Yeah. I know. We don't know a lot about the circumstances behind that employee, if they're there all the time, they can't, what exactly their job is. So, certainly there are details here that may make things clearer, but it's true. It is very interesting. And, I think it also speaks to some of the concerns, we're having now in terms of, folks that are not necessarily in contact with, or that are in situations in which they're coming into contact with a lot of people, not just healthcare workers, but, for example, people that work in the hospitals, staff, et cetera.
Yeah. And not to make this all about me, but that was also a big part of the reason why I cut all my hair off was because, I've heard, going to a barber is not great for a lot of different reasons. I've heard about some people having people come to their house to cut their hair. But then if they're going to come to my house, cut my hair, I pass them the virus and they go to somebody else's house and somebody else's house. That just seems like a big nexus of spread. And I don't really have any major science behind that, but that just seemed bad. My hair was getting too puffy. It was annoying me. So I figured it was just a matter of time.
I know we didn't even call that out. Information.
Yeah, it's, not ideal, but I don't know. It'll be another marker for when we return to normal. All right. So welcome. Jose P. has joined us as well. We're going to move on to our last paper for today. This is an interesting pharmacoepi one on the ischemic and bleeding events among patients with acute coronary syndrome associated with low-dose Prasugrel versus standard-dose Clopidogrel treatment. This is by Shoji and colleagues. So this is a database study from Japan. It's the KO Interhospital Cardiovascular Studies Registry for PCI, which is a 4-hospital database in Tokyo, Kanto, in Japan, and it's modeled after the NCDR in the U.S., specifically made so that it can be compared. They overall we're looking at 22,000 patients who got PCI from 2008 to 2018, but specifically we're looking in this study on 2,600 patients with actual ACS, with acute coronary syndrome, and who got dual antiplatelet therapy with either Prasugrel or Clopidogrel. And if you look at figure 1, the little light blue line that goes up shows just how much Prasugrel became more popular during that time, and is now accounts for I think 80% of the antiplatelet use that happens in Japan. This is very similar to what happened in the U.S., where basically there's 3 generations of these PY2 inhibitors. clopidogrel, prasugrel, and ticagrelor. And my understanding from reviewing this a number of years ago is that basically as you go up in the generation of these, you have a bigger decrease in cardiovascular bad outcomes, but a bigger increase in bleeding outcomes. And that's basically what they found here as far as bleeding. So they were specifically looking at low-dose prasugrel. So that's a 20 milligram loading dose and then 3.75 milligrams daily, which is pretty low dose. And the patients who received prasugrel in the study were actually lower risk for bleeding than the clopidogrel patients by their bleeding risk scores. But despite that, there was more statistically or clinically significant bleeding events in the prasugrel group, about 5% versus 1.8%. That being said, that's only 45 patients versus 16 patients. The minor bleeding was a little bit higher as well, 15 versus 8%. And the risk factors they found, there were associations with patients with higher risk for bleeding, patients who are female, patients who are having STEMIs, not NSTEMIs, as well as patients with CKD, which, none of these are really surprising as far as things that are more likely to lead to bleeding. I think it's just interesting here because, I think overall there's pretty broad consensus that dual antiplatelet therapy is helpful in patients with ACS. But, it's like with everything, there's trade-offs, and the trade-off for, fewer cardiovascular outcomes versus more bleeding problems.
Yeah, definitely. And I thought one of the things that I thought was sort of interesting that the authors talk about in the discussion is the fact that this is sort of a unique study because it's specifically looking at East Asian patients. And, these patients have different characteristics in terms of their atrial fibrillation as well as with bleeding complications. So I kind of appreciate it from that perspective too, just, being able to see that there are different rates of complication that can be related to, region-specific or ethnicity-specific things.
Yeah, absolutely. Yeah. So it's good stuff. Again, I think, there's a ton of different things we do to the bleeding class cascade, a lot of different things to factor as far as revascularization, as far as the cardiovascular outcomes versus the risk of potential harm. So it's always nice to have another piece of the puzzle here. Great. Well, that's what we've got for this week. Thank you for joining us. Again, I think we're getting over some of the speed bumps in our move to remote JNO Live. Of course, join us next week, 3 p.m. Tuesday the 14th, 3 p.m. Central Time. Follow us on all the social media channels. Get these papers and more at jamanetworkopen.com every morning, 10 a.m. Central Time. And, of course, stay safe.
Thanks, everyone.
Take care.